Hello, my name is Dr. Patel, and I'm a second-year internal medicine resident at Oklahoma State Medical University Center. Today I would like to present a unique case of drug-induced thrombocytopenia, specifically vancomycin-induced IgG thrombocytopenia. I would like to recognize all authors who contributed to this case report presentation equally. The patient's information has been removed to protect the patient's privacy. Drug-induced thrombocytopenia is an interesting phenomenon. It is associated with whatever drug was given in the hospital setting or in an outpatient setting. There's many causes before we confirm the diagnosis of drug-induced thrombocytopenia. Drug-induced thrombocytopenia should be considered in hospitalized patients without unknown explanation of infection, such as HIV, hepatitis, hemolysis, or immunosuppression from chronic disease of the liver. Drugs can either directly suppress the bone marrow or other organ toxicity. This case is unique in the context of giving broad-spectrum antibiotics, specifically vancomycin, for suspected gram-positive pneumonia. Thrombocytopenia was profound within 24 hours after being exposed to vancomycin. Further testing for antibodies to broad-spectrum antibiotics revealed IgG antibody positive for vancomycin. Patient was instructed to never be exposed to vancomycin again and documented in the medical record. Various inciting factors can lead to the formation of drug-induced thrombocytopenia, in which the mechanisms involved antibody-mediate platelet destructions caused by exposure to a certain drug. Other causes include heparin-induced thrombocytopenia, primary immune thrombocytopenia, and non-immune drug-induced thrombocytopenia. Drug-induced thrombocytopenia is due to antiplatelet antibodies binding non-covalently to specific platelet antigens via their Fob regions. These antibodies cause a rapid drop in platelets seen in drug-induced thrombocytopenia. Not only vancomycin, but other common drugs include quinidine, penicillin, rifampin, ceftriaxone, Bactrim, ibuprofen, mirtazapine, and other commonly used chemotherapeutic agents. In order to confirm the diagnosis, confirm that the thrombocytopenia is not due to clumping, for which an EDTA test can be repeated, and or repeat the platelet count. You have to consider other common causes first, like ITP, TTP, and multiple dysplastic syndrome. Infections like HIV, hepatitis C, EBV, H. pylori, sepsis with DIC, parasitic infections, alcohol and nutritional deficiencies can cause thrombocytopenia as well. Autoimmune disorders like rheumatoid arthritis and lupus, chronic liver disease, pregnancy, and other different types of antibody testing should be considered. Here we have a case where a 74-year-old female was admitted for severe hypoxia and hypercapnic respiratory failure secondary to COPD exacerbation. She was empirically started on IV corticosteroids and antibiotics, including vancomycin, levofloxacin, and cefepime for her pneumonia. Her platelet count dropped drastically from 272 to 1 in 24-hour period. The patient was empirically treated for ITP secondary to drug-induced thrombocytopenia with IVIG and high-dose corticosteroids. Drug-dependent platelet antibody panel returned positive for IgG vancomycin. This case demonstrates the importance of recognizing and treating an infrequent cause of drug-induced thrombocytopenia due to a commonly used medication. As you can see, your hospital labs are noted in the hospital labs section, and Adams TS13 was within normal limits, indirect Coombs test was negative, direct antibody test was negative, ANA was negative. Peripheral smear did not show any type of morphologic evidence of hemolysis, nutritional deficiencies, or myelodysplasia. Antibody testing was positive for vancomycin IgG, and the titers were elevated at higher levels. Their 4T scores were also performed, but it was low, as the probability was less than 5%. Imaging was performed for any other causes that would contribute to the thrombocytopenia. Right basilar consolidations and right pleural effusions were noted, likely consistent with her pneumonia. CTA, head, and other imagings were done as patient was becoming hypercapnic for fermentation. Patient was ultimately discontinued off vancomycin and continued to treat with corticosteroids as well as antibiotics. Patient was ultimately weaned off antibiotics and tapered off a steroid dose. Patient was ultimately discharged from the hospital with follow-up with her primary care provider and given pulmonology follow-up for her COPD. I would like to thank OSU Medical Center and my colleagues, Dr. Magana and Dr. Syed, for this case presentation. I would also like the Department of Internal Medicine at OSU to help me write this report. Thank you for your time.